Hi everybody, and welcome to our module on childhood psychiatric disorders. Let's start by talking about Rett syndrome. This is a neurodevelopmental disorder that only occurs in females, and it shares some similarities with autism, but in terms of board questions, autism is almost always going to be described in a male, and that's because autism is 4 times more common in males than females. In contrast, Rett syndrome occurs only in females. Girls with this disorder have initially normal development and then a slow onset of symptoms at about 1 to 2 years of age. And the hallmark of this disorder is regression of cognitive and motor skills. This is one of the diagnostic criteria for the disorder. And this also contrasts with autism. So children with autism are basically born with a disorder, although it may not be recognized until they are 2 or 3 years of age. In contrast, girls with Rett syndrome are entirely normal with normal development until the onset of the syndrome, and then they begin to regress and go backwards in terms of their functioning. Some of the clinical features of Rett syndrome are shown on this slide. First of all, girls with Rett syndrome have a deceleration of head growth. So when you take babies and young children to the pediatrician, their head circumference is measured and plotted on a growth chart. And normally, as the child grows, the head circumference increases at a steady rate. What you see in Rett syndrome is a deceleration of that rate of head growth. And the way you can think about this is that these girls have abnormal brain function. We'll talk more about that in a minute. So you can just think that their brain isn't growing normally, and therefore their head is not growing normally. In addition, because of the brain dysfunction, there's a loss of skills. Remember, the hallmark is regression of skills that the girl once had. So there can be a loss of motor skills, intellectual skills, and speech ability. There can also be a loss of balance. This is called ataxia. So this will be in a child who was beginning to walk normally and now loses the ability to walk. Another classic feature is repetitive hand movements. So girls with this syndrome will often lick their hands. Sometimes they grab at their clothing or hair, and sometimes they wring their hands. And once again, children with autism can sometimes have repetitive movements, and this may make you think of autism. But remember, autism is almost always going to be described in a boy, and Rett syndrome only occurs in girls. This is an X-linked disorder. It's X-linked dominant, so that if you have one abnormal gene, that leads to disease. And for this reason, it's fatal in boys. I'll explain that in a minute. In 99% of cases, there is a sporadic gene mutation, so there won't be a family history of this disorder. And the gene that's been implicated is called the MECP2 gene. This is mutated in girls with Rett syndrome. This gene is found on the X chromosome, and there's significant expression in the brain, and that's why these girls develop motor and cognitive regression of skills. So in female babies born with the Rett syndrome gene mutation, they will have one normal copy of the MECP2 gene and one that is mutated or abnormal. Because of random X inactivation, some cells will express the normal gene, and the result is that the child will survive but will have symptoms because some cells in her body express the abnormal gene. In males, they only have one X chromosome, so if a male inherits the gene mutation, they will have all abnormal MECP2 genes and all abnormal expression, and this is lethal. Boys with this gene mutation either die in utero or shortly after birth. Now let's talk about conduct disorder. Conduct disorder is a childhood behavioral disorder where children repeatedly violate the rights of others. And you can basically think of conduct disorder as the worst behavior you could imagine in a child. This is the kind of kid who gets in trouble with the law and ends up in juvenile detention. So children with conduct disorder display aggression to people and animals. One of the classic things for them to do is be caught torturing their pet, like their cat or their dog. They also destroy property. They also lie and steal. Once again, the type of things that get people in trouble with the law. And if this behavior persists into adulthood, which it does in some children with conduct disorder, they are then diagnosed with antisocial personality disorder, which is a similar condition that occurs in adults, and I talk about that in the video on personality disorders. Oppositional defiant disorder is also a disorder in which children behave badly, although it's not as severe as what is seen in conduct disorder. Children with ODD are angry and irritable, and they argue with authority figures. They can be defiant, and they can be vindictive towards parents or teachers, meaning that they get angry when parents or teachers try to reprimand them or modify their behavior. And you may know that lots of kids display this behavior. Probably half the kids in my elementary school classes did things like this, and I did it myself. What defines oppositional defiant disorder is that kids do it to an extreme and in a persistent manner. Some of the diagnostic criteria for ODD are shown in this slide. First of all, the defiant behavior has to occur with at least one person who is not a sibling. If everyone who fought or argued with their brother or sister had this disorder, then we diagnose it in 95% of children. It has to cause problems at work, school, or home, and it can't be explained by substance use or some other psychiatric disorder like depression or bipolar. And then finally, it has to last at least 6 months. So many children go through phases where they develop bad behavior for a short period of time that resolves. That is not oppositional defiant disorder. This has to persist for at least 6 months. The treatment is behavioral therapy with a therapist, and in most children this resolves as they grow up and mature. Disruptive mood dysregulation disorder, or DMDD, is a new childhood disorder that was added to the DSM-5 in 2013. This is controversial because it shares a lot of symptoms with oppositional defiant disorder, and some of the symptoms that are described, like irritability, are common even in normal children. And because it's a new disorder, there are relatively few established treatments. Some of the diagnostic criteria are shown on this slide. It's a childhood disorder, so it must occur before the age of 10. Children with this disorder are excessively irritable or angry. And then the hallmark of this disorder, and the way you will recognize it in a board question, is these children have frequent temper outbursts or temper tantrums where they lose their temper and thrash around angrily. These have to happen at least 3 times per week, and they have to occur in at least 2 settings, like the home or school. If they only occur in one setting, it may be a specific problem with that setting. And then finally, the behavior has to be out of proportion to the situation. So for example, the child will have a temper tantrum over something that happens at home that should not cause such a severe reaction. As I said before, this is a new diagnosis, so there aren't many established therapies. Some of the things that have been tried are behavioral therapy, antidepressants, stimulants, and antipsychotics, but nobody is really sure what works best for this disorder. So here's Dr. Ryan's slide for how to make a diagnosis when you're faced with a board question involving a child who is behaving badly. If the main problem is that the child is not paying attention in school and is hyperactive, then they're probably talking about ADHD. If the main issues are that the child argues with his parents or teachers and is defiant, then they are probably talking about oppositional defiant disorder. And remember, that behavior has to last for at least 6 months. If the predominant issue is temper tantrums, then they may be talking about DMDD. And finally, remember that conduct disorder is the worst behavior you can imagine in children, so these children are destroying property and displaying aggression towards other children and teachers and even animals. That is what defines conduct disorder. Separation anxiety disorder, as the name implies, is a childhood anxiety disorder where children have distress when they have to either leave home or separate from their parents. So children with this condition may refuse to leave home, or they may refuse to go to school. They also worry about losing major attachment figures, like they may worry that something will happen to their mom or dad if they are not close to them, and for this reason they persistently refuse to go out. And you may be aware that lots of children refuse to go to school and have problems along these lines. What defines separation anxiety disorder is that the symptoms are excessive and that they don't go away with time. Another common feature of this disorder is children will report nightmares about separation from their parents, and they also will repeatedly complain of physical symptoms, things like headaches, upset stomach, nausea, and these generally occur whenever they have to separate or they're getting ready to separate from their parents. The treatment is with therapy. The goal is to teach children coping skills. This is sometimes done with cognitive behavioral therapy. It's also sometimes done with a special kind of therapy called parent-child interaction therapy, where the parent interacts with the child in a room and a therapist watches the parent behind a one-way mirror and gives the parent's advice through an earpiece in the parent's ear. Now let's talk about Tourette syndrome, which is a neurologic disorder that occurs in children. And the hallmark of Tourette syndrome is recurrent tics. Children with this disorder display sudden, quick, repetitive movements or speech, and these are called tics. We'll talk more about these in a minute. And the reason Tourette syndrome is often discussed in the context of psychiatry is because it very commonly co-occurs with other psychiatric disorders. And it's high yield to remember this. They often ask about this on board exams. In particular, about 60% of children with Tourette's also have attention deficit hyperactivity disorder, and about a third of children have OCD. And the way I've always remembered this is that children with Tourette's have such severe hyperactivity, or they are so compulsive, that in addition to the behavioral symptoms, they start to develop motor and speech tics. That's the way I've always remembered this. So as I said on the last slide, children with Tourette syndrome can develop either motor or speech tics. So the motor tics are sudden, quick movements. For example, some children will blink their eyes frequently or jerk their head or grimace. And if you ever meet a child with Tourette syndrome, you'll notice that they do these things over and over again. The speech tics are also called phonic tics. These are sudden, quick elements of speech, usually just a few words that the child will repeat over and over again. And even though it's rare, Tourette syndrome is somewhat famous for causing a feature called coprolalia. This is when a child repetitively says a bad word or obscene language over and over again. This is seen in a minority of cases of Tourette syndrome. There's no diagnostic test for Tourette syndrome. It's diagnosed based on clinical criteria. To have this disorder, children have to have tics for at least 1 year. The tics have to begin before 18 years of age. This is a DSM-5 criteria. There must be multiple motor tics and one or more phonic tics, and the tics have to occur at many times of day and not be explained by some other type of neurological disorder. Let's talk about the treatment of Tourette syndrome. First of all, behavioral therapy has been used, especially if a child with Tourette syndrome also has OCD or ADHD. And then there are some drugs that have been used to treat the tics. The first class of drugs are dopamine blockers, the high-potency neuroleptics. I talk about these in the video on antipsychotic drugs. Drugs that have been used for Tourette syndrome include fluphenazine, risperidone, haloperidol, and pimozide. All of these drugs block the postsynaptic D2 receptors as shown in this picture, and that's why they are used to eliminate or minimize the tics. The neuroleptic drugs have lots of side effects, which I talk about in the video on antipsychotics. So for that reason, the drug that's more often used in Tourette syndrome is called tetrabenazine. This drug causes dopamine depletion in the central nervous system. The way it works is by inhibiting a transporter called VMAT2. VMAT stands for vesicular monoamine transporter type 2. And what this transporter does is it takes up dopamine and packages it into vesicles in the presynaptic neuron, as I've shown in my picture here. So if you inhibit VMAT, less dopamine enters vesicles and there's less release of dopamine from vesicles. So a key point here is that this drug works on the presynaptic neuron, whereas the neuroleptics I talked about in the last slide work on the postsynaptic neuron. And this drug also has far fewer side effects than the dopamine receptor blockers like the neuroleptic drugs. And then a final class of drugs that is sometimes used to treat tics in Tourette syndrome are the alpha-2 agonists. These are drugs like clonidine and guanfenazine. I talk about these in the video on ADHD because they're also used to treat that condition. And that's an easy way to remember that ADHD and Tourette syndrome often go together. What they do is they activate alpha-2 receptors in the prefrontal cortex, and for reasons that are poorly understood, this regulates attention and behavior. That's why it's used in ADHD, and it can also improve some of the motor tic symptoms in patients with Tourette syndrome. And I'll finish with this one slide on learning disabilities. So the technical definition of a learning disability is difficulty acquiring, retrieving, or using information. But what it means on a practical level is this usually describes a child who has a specific problem in one area, like math, reading, or writing. The child won't have behavioral problems, there won't be evidence of global cognitive dysfunction, but the child will simply struggle in one particular subject. That usually defines a learning disability. And that concludes our video on childhood disorders.